Today we're discussing computerized physician order entry, barriers and best practices, specifically from physician and provider perspective. I'm Mary Zile with Scott Pettigrew. I'm a nurse, the Director of Practice Consulting at the Tri-State REC with extensive clinical background in outpatient, inpatient, EHR implementation in 2001 and quality programs throughout this community.
And I'm Scott Pettigrew, the Medical Practice Consultant here at HealthBridge and the Tri-State Regional Extension Center. I have 13 years of experience in medical IT, ranging from the vendor side of the equation to the clinical side of the equation. I have helped many doctors implement computerized physician order entry, specifically with regards to prescriptions, but also EHRs, EMRs throughout all levels from small practices to enterprise level.
As far as the session objectives, we're going to discuss the necessity of changing from paper prescriptions to CPOE. We're going to go over the common implementation barriers with specific significance on rural and critical access hospitals, and we're going to discuss best practices for these regions as well. When you consider the need to go to CPOE, we need to first address what the problems are with paper-based medication systems and order entry. Some of those issues include illegible written medications, which may be the physician handwriting. For instance, BID versus TID versus QID could be twice, 2, 3, or 4 times a day, which is doubling the dose. You can have inaccurate or incomplete medication orders, which could be missing doses scheduled. You could have no route indicated. You could have the wrong route interpretation, such as IV versus IM, which is intravenous versus intramuscular, which is a significant problem. On paper, you have an inability to check drug-to-drug interactions, drug-to-disease, drug-to-lab, drug-to-allergy, and drug interactions and contraindications. For instance, amoxicillin versus augmentin are both penicillins, and it's hard to double-check the allergies on a paper system consistently every time. You also have unnecessary variations in care and difficulty adhering to medication and treatment guidelines. For instance, with ACE inhibitors as an indication for diabetes, to make sure you follow that guideline every time. You also have difficulty adhering to formularies, including callbacks from pharmacies, which can result in patient confusion, increased cost, and more work at the primary care level. In total, there's 3.52 billion prescriptions written annually each year, and each one of those is a source of error. So why computerized physician order entry? A summary slide, the Institute of Medicine to Err in Human went through multiple studies, including the Harvard Medical Practice Study and the Colorado and Utah Hospital Study. And those studies showed that 44,000 Americans die from medical errors each year. In addition, there was a New York study that showed 98,000 deaths per year. All in all, this results in 7,000 annual deaths from medication errors, with 5 to 15% ambulatory adverse drug effects, events, and the cost of errors costing the society over $2 billion per year. As far as the CPOE definition, the American Hospital Association defines CPOE as a system for direct entry of one or more types of medical orders by a physician to a system that transmits these orders electronically to the appropriate department. It can include alerts, drug information, access to evidence-based guidelines, and degree of decision support functionality. It includes more than just physicians. It can include certified nurse practitioners, midwives, and others as by the authority of law for the state. And so in essence, CPOE creates a process using clinical guidelines, defining medication and procedure lists, and it creates a process that makes it repeatable, accountable, physician-endorsed, documented, and the ultimate goal result is to result in reduced work, reduced clicks, and increased patient safety. As far as Stage 1 and Stage 2 comparison for eligible hospitals and critical access hospitals, for the Stage 1 objective, it's to use CPOE for medication orders that are directly entered by these licensed professionals into the electronic medical record, and the measure is for more than 30% of unique patients with at least one medication in their medication list for those eligible hospitals and critical access, inpatient and emergency room departments. The differences for Stage 2 is that Stage 2 adds laboratory and radiology orders in addition to these medication orders. Medication order CPOE goes from 30 to 60% as far as the Stage 2 measure, And for laboratory, it's 30% by CPOE, and for radiology, it's 30% of radiology orders by CPOE. The CPOE Conundrum. Processing a prescription drug order through a CPOE system reduces the likelihood of error by 48%. So we have proof that paper-based medication prescription causes errors and that e-prescribing reduces errors. Why isn't everyone using CPOE? So there was a study that showed that the two major barriers are cost and physician resistance, and the overall strategies for reducing these barriers are to overcome this by placing patient safety at the top of the agenda. So regardless of physicians, administration, and staff not agreeing on everything, we can all agree that we can help to improve patient safety. And the barrier for physician resistance is to stratify, leverage strong leadership, external influences, vendor commitment, and the presence of house staff and hospitalists. Okay, so despite the CPOE system's effectiveness at preventing these medication errors, adoption and use in U.S. hospitals is slow. A study in 2003 showed that only 5 to 10% of hospitals were using these systems. So Scott and I are going to discuss what these barriers are and what the best practices are. As far as the cost for these CPOE systems, it can be $10 to $30 million for large systems and $3 to $10 million for small systems. There's an uncertainty on investment for the return of your investment. There's potential negative impact on physician workflow, potential physician rebellion, and difficulty training, especially in the rural, under-resourced community hospitals. And the studies have shown that out of all attestations in these hospitals, that CPOE is the greatest barrier to overcome in order to get attestation. These CPOE lags, specifically for rural community access hospitals, include lower level of resources, especially in the rural communities. There's a poor payer mix, increased Medicaid and self-pay. There's also difficulty accessing capital loan programs or understanding how to proceed with new programs that are coming forward. There's an expense with the CPOE enhanced functionality. For these rural hospitals and community access hospitals, there can be an increase of the operating costs from 19 to 30%, which is a huge burden for these hospitals. In addition, there's limitation in internet accessibility, with the FCC study showing that there was no business case to offer broadband in certain situations, and so internet does not necessarily proceed as quickly in these rural communities. There's also local pharmacy limitations in accepting e-prescriptions and limitations in administrative time and priority related to work burdens that relates to this extensive project implementation. As far as continued lags, there's also difficulty for rural facilities to find, afford, and retain highly trained staff. This includes IT staff, physicians, and other ancillary staff. 20% of the population lives in rural areas. Only 11% of the physicians practice there. These physicians are more toward retirement age. So there's a greater dependency on the existing staff, and these skill sets are not typical for physicians and a lot of the staff in rural communities. There's also limitations in IT staff coverage. There's difficulty when you only have 1 to 2 people in the department to have a 24/7 coverage, and it's just an extremely limiting project to implement CPOE in under-resourced departments. There's also an increased workflow demand for ED CPOE complexity compared to other ED software. Typical ED software has more of a passive functionality, where CPOE has extensive alterations in workflow. It requires additional efforts from the staff and the primary care physicians and the emergency room staff. And we have to remember that this is an emergency room, and physicians and staff are there taking care of emergencies. So this is an extra layer of complexity that can't always be easily acclimated into their workflow. In addition, as far as implementing CPOE throughout a hospital system, there's many interactions with other departments that have to be taken into account. And so with the shortage of physicians in the rural areas, there's also a shortage of the younger physicians who are trained in technology, and so to implement a CPOE in a critical access hospital area, there's extensive obstacles to overcome. So the CPOE barriers include vendor, hardware, software, administration, staff and provider, workflow, patient safety, and patient perception. First, we will address vendor barriers. These vendor barriers can include inadequate or misappropriated training for CPOE compared to other full EHR systems. Many times this CPOE implementation is not considered a project. There's a lack of project management or project management expertise in these facilities. And so that results in a lack of time allocation, not enough dollars, and the training schedule is not clearly defined if there's not a good project management documentation. There's also inflexibility of vendor schedules to accommodate providers and staff for CPOE training. Many rural communities have fewer staff. They have many other projects to work on. There can be gaps in education and training, and there can be critical staff attrition for these members, and so you can create critical points of failure either before, during, or after the implementation. So you, as far as the CPOE workflow, if you don't go with a very clearly defined plan and you have a poorly designed CPOE flow, it adds chances of error throughout the implementation and the post-implementation phases. There can also be poor modular integration. You have many departments, even in a rural or critical access hospitals, which can include lab, ER, radiology, extended care, physical therapy, and of course the inpatient beds. And all those have to interact as far as workflow. The different departments have different needs, and they may have different software that doesn't marry together. And also the limitations in technical support and customer services. When you have the implementation of CPOE, you have to plan for the training and make sure that you have adequate resources for that. So limitations in this can be result from the vendor issues, not prioritizing the needs of the critical access hospital, or it can be a result from the hospital purchase, but either way you have to make sure that there's enough training available for your CPOE implementation and post-implementation training. As far as hardware barriers to rural and critical access hospitals, there can be internet access limitations, which is limited availability in the area. There can be spotty service or slow internet speed. There can be expense and access to wireless networking, which Scott will address more. There's security concerns without adequate IT expertise. There's extensive policies and procedures that have to be followed and written. You have to undergo mitigation strategies, and privacy and security, especially because CPOE, privacy and security becomes a continued process that has to continue past post-CPOE implementation. And then also the budgetary constraints. Hospitals have to choose between CPOE implementation and other competing priorities. As far as software barriers to rural and critical access hospitals, there can be lack of system integration, poorly designed user interfaces, and the lack of ability to build order sets. Some CPOE systems are marginal, and they may have been chosen because they were part of an existing software package, and so it may result in an extensive expense related to a lot of software modifications, or now you have high expenses related to poor designed user interfaces or lack of system integration. And because of these issues, there can be a delay in the software updates for new medications, medication recalls and interactions, and there can be a delay in all these software updates. And some of that's related to vendor immaturity, where the vendor really wasn't ready to enter the CPOE market, and so their resultant service after the fact may not meet the needs of the hospital. And some of these systems also have lack of the barcoded EMR systems. As far as the administrative barriers, the administration may not have a high priority to implement these systems. In the critical access hospitals, they sometimes take the easiest path. They may have a reluctance in setting the priority for this policy. And really the main thing is to build all the project components, the staff requirements, illustrate that there's an extensive amount of teamwork and an extensive need for subject matter experts, which is to build the plan for this process. And it's a large time requirement even for the administrative staff, and it may not become their highest priority or their greatest need. There may also be inadequate goal feasibility and then with inaccurate goal setting, and also inadequate time management, which isn't built into a project plan. Because of this, too, you may have underestimated staff resources and not follow this implementation plan through to the staff. And then also, too, as you implement CPOEs, you have to have some way to evaluate the barriers. And you have to define that process and make sure you have a way to channel any negative feedback to create better process implementation as you go. There may also be an undefined process. The personnel may not understand the process or have a way to report back the errors or how to change or update these plans. And a lot of this also, there may be lack of time to fix vendor issues and barriers, and also, too, government regulations and para requirements in addition to the CPO implementation adds a lot of complexities that critical access hospitals don't necessarily always have the time to overcome. As far as provider and staff barriers, there's also, too, priorities over CPOE implementation. You know, the physicians have to take care of patients. They're the patient there in front of them. And this is seen as maybe potential work that can help the patient, but also more work, unnecessary work, and they already have time constraints. And so they may not be vested to get proper training. There may be time constraints with their other jobs, their other duties, their other department work. And initially, there's a reduced productivity. I mean, this is really more work from a paper-based system. A paper-based system is quick. You write a script. They know how to write. For CPOE implementation, especially the early stages, this may result in better safety, but it's more work and more time constraints at the beginning. And they also have a fear of error in their CPOE. And we have to remember there's 98,000 deaths for medical errors. And every time a physician makes a decision or writes a prescription, they realize that they have to monitor the safety on that, whether that's papers, prescriptions, or CPOE. And so they have a fear of implementing into a new system that may affect their patient care. And then again, there's different technological aptitudes between older and new staff, computer savvy versus physicians who have never used a computer or a mouse. And then as far as physicians, they also look at the view of when they write a written prescription, it's a thinking process. When they click through a computer, you can have click errors. And so that's also meets some resistance from physicians. The CPOE can affect the patient flow and productivities. And with over 3 billion prescriptions written each year, physicians know any error can cause increased morbidity or mortality, so they're cautious of the whole clinical care process anyway, in addition to having extra work on top. And then there's also impact on the physician as far as user interfaces. If there's patchwork solutions across the departments, across different time, across different software, they have increased time to learn. There's impact across the systems and how those systems interact, and that also affects the clinical care. Also, too, in critical access hospitals, you have issues sometimes with contracted providers not being vested employees of the hospital. You have also multitasking of staff with multiple job descriptions and not always a full staff. Some of the local pharmacies in the rural critical access hospital regions don't have the ability to receive e-prescriptions, and all in all, rural pharmacies have lost 853 rural pharmacies from 2003 to 2001. So in the rural community, you're losing some of that camaraderie where you can talk to different specialists and different pharmacists for clinical discussions. And e-prescribing, as far as the implementation, you have to be aware of how that impacts the communications with the other specialists and experts that the physician works with. Also, too, with the formularies between hospitals and outpatient clinics, physicians are going between hospitals, different departments within the hospital, maybe their own practice, maybe nursing homes. So they have different EHRs, different formularies across those systems. And so it's not only extra work within your facility, it's extra work cumulatively with all the other sites that these physicians may practice in. As far as workflow barriers related to CPOE, there's sometimes lack of standardization medical terminology in these computer systems, so physicians may be learning a different language for ordering different types of tests and medications. the workflow and process redesigns can be issues. These detailed integration of workflow may not be as productive initially. They have to find new ways to store information and retrieve that information, and all this takes more time, at least initially. And when you implement a CPOE, many people think that you're going to have, the staff is going to have more time, where initially it takes more of the staff time, so everyone has a greater work burden. And then, as I said, there's less peer support in the community in these rural areas. And then also, too, you may have new implementations of CPOE within the different departments, but you need to have the old system running if there's not a good transition of the data or a good interface. So the doctors may not only be learning a new CPOE, they may have to access data in the old systems to look at lab trends, radiology, and medication historical data. And we won't go into these in detail. There will be continued studies about the impact of CPOE on patient safety, but patients won't necessarily have paper prescriptions in their hands anymore, and so it's a learning curve for those patients. Those e-prescription goes to the pharmacy. There's confusion, and the patient has to be clear of which scripts to pick up now versus which they need to put on hold. And also, too, the patients really need to be aware of continuing monitoring their medications either through their pharmacy or through the clinical summaries, because it's their medication, it's their health, and they need to be aware of, as well as physicians as well, as far as the safety of their medications, whether it's on paper or CPOE. And then also patient perceptions. Some physicians do still feel the fear that they're not sure what their patients are going to expect. The e-prescription goes to the pharmacy. Doesn't necessarily mean that the medication is ready when the patient gets there. And so some of that is extra training that the physician has to do for the patients. And then as far as fear of patient satisfaction, either whether that's real or perceived, and real or perceived patient safety issues. And then also, too, limitations on patient education as far as that training session at the physician face-to-face with the patient is, physicians have fear of just sending the scripts through to the pharmacy system and lacking that direct paper transition to give patient new information. And I will hand it over to Scott, and he will address best practices.
Thank you, Mary. We're going to be covering today best practices in rural and critical access hospitals with regards to training, workflow, system configuration, goal attainment, and change management. And we'll start off with training. So when we take a look at rural CPOE training, we want to look at, as Mary covered, oftentimes there is not good project management in these smaller resource-strapped hospitals. And this presents a huge problem as far as uptake of CPOE. So we really need to make sure that we have a good and experienced project management staff to assist with the implementation process. Clear communication absolutely clears the way to a better implementation. We need to develop our summary of CPOE benefits to physicians, including order sets, decisions, supports, and alerts. We really have to sell the product. We need to have our elevator speech, as it were, so that we can summarize these benefits in a very clear and concise manner. We have to show the benefits, to show the patient benefits in reduced medication errors, reduced adverse events. And we also have to show that there are tools to ease this transition, that we can actually set up macros, that we can set up order sets to allow the physician to work with CPOE much more easily than he or she might anticipate. We have to look at the gap analysis. We have to actually do, on an ongoing basis, an analysis of where do we want CPOE to be in our facility, and also where are we at now. And that allows you to do a continual quality improvement type of analysis structure where you are constantly making tweaks and changes in a very structured, ordered manner in order to improve. In order to do that, though, you have to have a methodology in place, a consistent methodology for system evaluation and testing. So we have to take a look at when we're actually making our purchase decision. First off, how are we evaluating these systems and how are we testing these systems? When we're going through the implementation phase and ready to roll out, how are we going to test these systems in a very methodical way, in a way that makes sense and is going to cover every aspect of CPOE within the enterprise? But also on an ongoing basis, in that continual quality improvement mindset, we want to make sure that we have a consistent methodology for saying, okay, this part of the system works great, this part of the system needs improvement. Getting that consensus from all of the stakeholders within the enterprise is absolutely critical. We want to make sure that in the implementation process that we capture the current order sets, standing orders, and best practices that are being utilized in the paper paradigm so they can be transferred over to the new electronic tool set. This is an absolutely critical step for allowing doctors to more easily take up the CPOE methodology. Also, provider and staff training checklists and tools for CPOE readiness start with recurrent training. So we want to make sure that we arm the staff not only with a one-time training, but also make sure that they have checklists and tools that they can refer back to. So it's not just referring back to what you saw during a one-hour training. It's also saying, okay, here is our workflow. Here are the steps that you need to do to achieve that workflow. Writing them down and allowing people to actually step through that process. It really does help. And having a quick guidebook at your fingertips is absolutely critical for a lot of people. Finally, patient safety teams with defined processes and data to mitigate current paper versus CPOE errors. So we know that CPOE is not infallible. It does reduce errors. But when we do, just as we would when we find a error in the paper-based system, we want to backtrack and figure out what is the root cause of an error inside a CPOE-based system. Sometimes that can be misprogramming, but more often it is a misunderstanding of the CPOE process, and we want to be able to tackle that very, very quickly. Continuing on with best practices for training. Very visible super user staff across all locations and shifts. I stress visible because when you go live, knowing who you can go to get some help is absolutely critical for the confidence of your end level users. In some of the go lives that I've been a part of, matter of fact, in almost every go live that I've been a part of, your super user staff is identified via some sort of highly visible T-shirt, maybe it a bright red, bright orange T-shirt. Could be a special badge that they have. It could be an actual list at nursing stations of who is the super user on call for that time. Anything that we can do to make it very, very easy for everyone involved to find in rapid order that person who can give them the help. Also, peer-to-peer or staff-to-peer partnerships, so training teams, if you will, to make sure that almost like a buddy system of a methodology, so that if one person understands a methodology better, they can actually transfer that on to a peer or to a trusted staff member, so that they both can understand much more of an interactive staff training methodology. Cross-training of adequately educated staff for building and keeping order sets up to date is absolutely critical, so that if the nurses know that at this time of year we see an uptick in flu intakes, so we want to be able to shift over order sets possibly, or shift over the actual ordering or numbering of the order sets so that certain things bubble to the top. Some systems do this actually automatically as order sets are used. Some do not. And so it is a very good thing to be able to have multiple levels of people looking at the order sets to make sure that they are up to date. Accessibility of webinar and written training materials, we kind of covered that with the checklist. But again, the refresher courses, so that people can go back. They go on vacation for a week. You're on the beach, you're not thinking about CPOE, you're not thinking about these systems. The ability to refresh your knowledge when you come back in a quick and concise manner can really help. User satisfaction survey. We want to make sure that doctors and everyone using the system, all of the providers, have an input mechanism to say, hey, this is working great, or hey, this is not working great. If they have an input into the system to make sure that they know that their thoughts and feelings are being handled, number one, they're more interactive in the process. They feel more empowered. But number two, they know that their any workflow issues will be taken care of, and they actually are more patient when that is the case, when they are demonstrated to have an input into the system. In order to do that, we have to have have a team that is able to review the physician issues, review the problems, the gaps in the compliance, so that we can actually do ongoing training. Training is not just something that you implement at the start of a CPOE process. There may be training at upgrades. There may be training as we tweak the system so that it is an actual ongoing process. As far as workflow, workflow, of course, ties hand in hand with training, simply because every time when you have workflow, you must train on it. So let's take a look at what we can see here. Internal leadership versus external facilitator for workflow lead. So internal leadership is going to say, here is our workflow as it existed before CPOE came in place. The external facilitator, oftentimes a consulting firm, or even more often the vendor, will show kind of the recommended workflow within the system. Our goal is to change a workflow in a way that provides balance and between the two systems, so that when you actually have your finalized CPOE workflow, it is not so alien to the users that it's unworkable, but it has to be close enough to the recommended workflow for the system so that it actually works within their system. Moving on, analyzing the organizational steps necessary to support the CPOE workflow change. Again, we want to do a gap analysis there. So where are we now? Where do we want to go? It may not be something we want to implement all in one fell swoop. It may be something we want to take in steps. So that gap analysis is very, very helpful. Process review and mapping of process by team. We do this at every implementation of an EMR, even at the smallest level. We take a look at what is the current process, because no two processes are completely the same. They're all similar. You have similar steps, but there are workarounds and workflow issues that are put in place by practices. They do it for a reason. We want to make sure those are captured so that if we do need to implement those at the larger level, that we are able to. Taking a look at all of those process mapping, system configuration, workaround workflows, we can actually go forward and define the system configuration, define those workaround workflows. But we have to have the process review, we have to have the gap analysis in place in order to actually define those system configurations. We also need to make sure that when we do that system configuration definition, that we actually get a consensus from all of the providers that this is how things are going to work. They want input at this level of the process, and input at this level of the process will lead to much better satisfaction as we go through the implementation process. Moving on. Analysis of root cause for workflow, vendor, or other barrier analysis. So we want to take a look at what is actually causing our problems. So if there is a problem with workflow, if the doctors are raising red flags, if your nursing staff is raising red flags with regards to the CPOE process, we need to figure out what it is. And sometimes the nursing staff isn't real clear, or the doctors really aren't clear about what the barrier is. They just say that, oh, well, it doesn't work for me. So we need to actually sit down with them, have them step you through the workflow, and listen very closely to the comments on why things do or do not work. Oftentimes, these barriers will be related to individual issues, so they prefer to see a button in a certain place. They don't do things the way that the training is. They may hold grudges. They may just think it's too many clicks. It may be a perception issue, an individual issue versus an actual system issue. Oftentimes, the fact that the system is moving too slowly is a perception issue. Not always. Sometimes there actually are database issues and other system issues that can cause these types of problems, but sometimes they are just perception. They're used to the very quick and easy methodology of writing a script, and we're stepping them into a new paradigm. And we want to actually, again, go through that process. And this is really a regenerative process. It's really a circular process for process redesign. It's not something you do once and then stop. It's always something we're trying to improve. Again, with that quality improvement mindset. Going into system configuration, we're going to leverage the technology to access medication expertise. Oftentimes, this is access to a website or to a Multum database that allows the doctors and providers to take a look at contraindications, at possible side effects that they may or may not be aware of, or to answer patients' questions instead of walking out of the point of care, to be able to, with a couple of taps, a couple of clicks, access this medication expertise right at the point of care. Order workflow and standards should be discussed ahead of time and revisited on a routine basis. Again, this is part of the quality improvement mindset, the plan, do, study, act cycles, which many people are familiar with. We want to make sure that we have a consensus on the workflow. We want to make sure we have a consensus on the standards. Many organizations in what we call canned prescriptions will utilize, for example, BID, the abbreviations, which can really reduce a lot of the advantages that you get with a CPOE system back to the same errors that we see with the paper-based systems. So we want to make sure that does the enterprise or does the organization want to allow these types of things, and make sure that these standards are discussed with the physicians so that they can modify their custom-made macros, and order sets, but also to make sure that the predetermined order sets and the predetermined canned prescriptions and canned orders completely are compliant with organizational standards. Again, make those standard or canned order sets available, but we want to make sure that they are specific to the user. It doesn't do a lot of good for for somebody who doesn't deal with OB/GYN to have a list of prenatal vitamins on their order sets. We want to make sure that they are able to access these things, but that we want to make sure that we really focus on these order sets by user, by specialty, by role, and or by location, because roles can change if a user changes location. We want to make sure that we focus in the configuration on security and data integrity. When you install these systems, we must make sure that for example, the wireless Mary talked about before, that the wireless internal to the organization has the correct level of encryption so that data security is maintained. We want to make sure that the security features are turned on that are appropriate to the facility. We want to make sure that sign-on and access both internally and remotely, and I'm segueing down into the next topic, we want to make sure that the access is available so that the users can do their job, whether they be internal or external to the facility. And this really provides an opportunity for a lot of breaches of security. So we want to make sure that we have the expertise in-house or available via consultants or outside IT organizations to help us maintain that security and document that security for our privacy and security requirements that all of these organizations must be doing. We want to do system analysis focusing on integration between ancillary systems. It doesn't do a lot of good to put in a CPOE system if it doesn't talk to the internal pharmacy. It doesn't do a lot of good to put in a CPOE system if it's unable to pull a patient's demographic system from the practice management system if they are not integrated. So we want to make sure that in doing these things that we are focusing on reducing repeated work, but also allowing data to pass as freely as possible, with maintaining the bounds of security, but allowing data to pass as freely as possible between the different organizations within the enterprise. Finally, as far as system configuration, we want to look at work process analysis and constantly redesign to maximize system functionality. Again, this is part of the continuing quality improvement mindset. So oftentimes when you put a system in place, it may not have a feature that your users desire. However, future updates will actually implement those features. We have to, number one, know that those are going into place. Number two, we have to know what, I guess this would actually be previous to this, know what features users want. Number two, know that those features are going into place. And number three, redesign that workflow and educate the users that this change is because of features that they have asked for in the past. So making sure that they know that these are available to them. As far as long-term rural goal attainment, the long-term financial plan and cost analysis of CPOE, obviously we know that that critical access hospitals and rural areas can pose very specific financial limitations on facilities within those areas. So we want to make sure that we have that long-term goal. We're planning for the future. This is not something you do and then you don't have to budget for. This actually is a budget line item every budget going forward for things like system support, for things like hardware updates, break fix. We want to make sure that we understand what those are going forward. We want to communicate the rural advantages of CPOE, especially within the organization, that this is going to increase safety, this is going to reduce liability, this is going to improve patient outcomes. And we want to make sure that all of our providers understand those advantages of CPOE. Defining goal definitions with realistic expectations, timelines, and revisions as needed. Again, this is part of the project planning process. So oftentimes when an implementation is finished and everyone's up and running, the perception is the need for the project management team goes away. To be honest, that's just ending one project and beginning another. We're always looking for the next upgrade, and these are all projects that do need to be handled. And if you don't have that project management in place, you are going to have problems with your with your finances with regards to CPOE. It goes back to within project management, they talk about the three constraints. You talk about time, you talk about resources, and you talk about money. And any one of those three, if one of those three shrinks, you cannot just leave that triangle to stand. You have to adjust accordingly. So we really do need to keep that in mind. One of the biggest things that I have seen in my 13 years of working within the clinical organizations is the need for a physician champion inside the organization for empowerment, involvement, and leadership. Usually this is one of the senior physicians within the organization, but not always. What I have seen is that a newer, very stalwart younger physician who understands the technology and can speak that language can really help bridge between these physicians who may be more resistant to the change in paradigm from paper to electronics. And I'll tell you what, in every case where I have seen an implementation fail or falter is because of a lack of physician leadership within the organization. We also have to have a physician advisor group. Again, we're not looking for complete agreement among providers of care as far as standards. We're not looking for complete agreement as far as order sets, but we are looking for a consensus. We want to make sure that everyone agrees, especially at first, that yes, this is good, we're moving in the right direction, with the understanding that we're going to continue to utilize their resources and their expertise down the road to help in that quality improvement mentality. Additional core group, again, CPOE does not just involve physicians. It also involves the administrators, the nurses, information services staff. It would also involve your pharmacists. So you do need to have input from all of the core groups that have stakeholders within that CPOE system. Final, enlisting CPOE champions with on-site assistance. Again, we need to know who is keen on the CPOE system, and make sure that they have a chance to be vocal, because oftentimes people who are pro-change are drowned out by people who are against the change. And so it's very, very important to have those positive voices be available to help in moderating a negative voice. And we are always going back to the flowchart analysis of goals to making sure that we are following our project plan. So the flowchart analysis of goals to assess progress and goal completion, this is all part of project management. Making sure that we are all moving towards our final goals, when we are doing our gap analysis, that we are making sure that the direction that we are going is the direction that we talked about and continue to talk about moving forward. As far as change management, this is oftentimes the hardest part of the process. And Mary talked about it. Mary talked about resistance within the organization. Mary talked about even resistance within the patients that come into a facility. Well, so we need to utilize good change management processes. And really what this comes down to in many cases is communication, is training, is providing a comfort level to those involved with the product. Although the bottom line in some cases may be this is the way we're going, you're going to adapt, or you're going to be left out of the organization. Not exactly the best thing to say to your workers. Not exactly the best thing to say to your staff as far as morale. So we have to take a gentler approach. Talking scripts from staff to patients to reinforce the necessity of change. So we want to make sure that everyone has their talking points to reinforce the fact that this is a change that is going to provide better care for everyone involved. The patients are going to have better outcomes. They're going to have less adverse drug-related events, less readmission to hospitals due to those events. So we want to make sure this is about patient safety. That's why we're doing this. Engaging the patients and staff in patient safety is absolutely critical, and it really talks to the two above. We want to make sure that communication is key. Where patients have good stories that, hey, the doctor was going to prescribe a drug for me that would have interfered with for example, my warfarin, and it caught that, and the doctor may not have known that without that. Those are great ways that we can communicate out to the community and let people know that this is a change for the better. And developing a patient handout of best practices, how to safeguard your pharmacy refill process, how to keep track of your refills, which can become difficult if you do not have a printed script in your hand. But if a practice or if a critical access hospital is going through the meaningful use process, educating them that while they may not have that printed script, they will have a clinical summary of that visit that will show what scripts were given to them. So oftentimes it's just, again, a little bit of education about how things are changing. Incorporating your meaningful use medication list, making sure that patients bring in a list of their medications so that we can keep their historical medication list accurate, especially where they have seen other doctors, so that, again, we can provide them with the best and safest experience possible. And then how to handle and update your medication list. That can be either via bringing in your list of prescriptions, or in some cases, it's even you're even able to do this via the portal. Although that is a particular, I think, underused at this point and just starting to grow. Mary?
And we have 2 slides here at the end that show the resources that we've based information on, plus our historical employment history. But just as a summary statement, your main goal is when you implement the CPOE in the critical and rural access areas is you want to create a real safety net for the physicians and the staff so that they know they're not in the process alone. They might be coding a patient 1 minute, and then they have to enter CPOE the next. So, and the patients really are the priority. So you want to make sure that all your education is very role and task specific as well, that you have a forum so that they can have a way to give back quick, non-judgmental feedback, and that there's a continual assessment by the staff and physicians to give that feedback to the system to ultimately improve the CPOE implementation and post-implementation processes. Because the reality is and what the CPOE implementation should focus on is patient safety and the improvement in reduction in errors in the CPOE implementation. And with that, we'd like to thank you for listening and to our webinar. Thank you from the Tri-State REC. You would either like to call or email us. Thank you.